ask your questions away, and we'll hopefully be able to answer those by the end there. But I do wish to welcome Sam, and Sam joined our team earlier back in March this year, and is representing Queensland. She's up in Brisbane. She's gained her nursing degree back in Durban in South Africa in 1994, and has been a haematology oncology nurse for over 25 years now. She's worked in a number of fields, including ICU, coronary care, haematology and oncology, and most recently, before joining our team, she was one of the nurse educators at a number of pharmaceutical companies, providing education to health professionals. So I'm really pleased to introduce Sam again. Hi, I'll let you take over.
Thank you so much, Donna. As Donna mentioned, today I'm going to be talking about immunoglobulin replacement therapy. It's not a very well-known topic in the lymphoma space, but hopefully for the people that are on today, it will be of some benefit to you. So firstly, what are immunoglobulins? So immunoglobulins are also known as antibodies. Antibodies are the proteins that bind to specific antigens. And antigens are toxins or foreign bodies. So antibodies are made in your body as part of the natural defense against infections. They protect your body from bacteria, viruses, and fungi, and anything that is really basically foreign to your body. So I'll be talking briefly about the type of immunoglobulins that are found in your blood. So there are 5 subclasses of immunoglobulins or antibodies found in the blood. So they're IgA, IgG, IgA, IgM, IgE, and IgD. And as you can see on the right-hand side, there's some pictures because the antibodies actually look slightly different. All right, so type of immunoglobulins in the blood. And as I've just touched on, there's those 5. So the most common one, and this is the one that we'll be talking about today, so it's Ig replacement therapy. This is the most predominant antibody found in the blood. So it makes up 80% of all those antibodies in the blood. And it's really the only antibody that has the ability to cross the placental membrane and provide immunity to the fetus. It provides immunity to the developing fetus. It also activates the complement pathway of the immune response, and also provides infection against pathogens in the blood and tissue. The next one is IgA. And this is found mainly in the mucous membranes of your gastrointestinal tract and your respiratory tract. And it's located in secretions such as mucus secretions, saliva, tears, and colostrum. So it's the function of IgA is really basically the first line of defense against any antigens that come into the body. It has a function of limiting inflammation, and it is associated with chronic infections, autoimmune diseases, and chronic diarrhea. The next one I'm going to talk briefly about is IgM. This is really the biggest antibody that's found in the blood. It's the first antibody that is produced when antigens come into the body. It's found in the blood and lymph fluid, and this activates the complement pathway of the immune response. And it works much the same as IgG, but is found in smaller volume. Then we get IgE. This is involved in hypersensitivity reactions or allergic responses. It's found in the linings of your respiratory and intestinal tracts, and it binds to mast cells, which causes that histamine release when you have a reaction. And the last one is IgD, which is poorly understood, but it's to the B cell activation. All right, so what is immunoglobulin replacement therapy? So intravenous immunoglobulin replacement therapy is treatment given to boost your antibody levels to narrow low. You may have one or more infusions containing a mixture of Ig antibodies from donors. This treatment can strengthen your immune system and help you fight infection. And it also might be known when you go into your hospitals or your infusion lounges as IVIg replacement therapy. It does not stimulate your body to produce its own Ig. It's just really only a temporary protection, which lasts about 3 to 4 weeks. So why do we have immunoglobulin replacement therapy or IVIg replacement therapy? It's basically when your own immune system can't make enough antibodies to fight infection, and so therefore you can't have a healthy immune system. So that is why we have it. It's given in the lymphoma setting for people that have symptomatic hypogammaglobulinemia secondary, so either to your disease such as follicular lymphoma or CLL, or maybe after you've actually had your treatments for those conditions. It's also given post bone marrow transplantation, and it can also be given for immunomodulating indications such as idiopathic thrombocytopenia purpura, but we are only going to be talking today about the replacement therapy, not the immunomodulating therapy. So as I touched on, people who may be diagnosed with CLL or follicular lymphoma might get something called secondary hypogammaglobulinemia. So this can happen either due to your B cells not functioning properly due to your lymphoma, or it can be due to your immune system being wiped out by chemotherapy and other treatments. So patients will often experience recurrent sinus infections, ear infections, diarrhea, and they often will get pneumonia and other respiratory infections. And these are really recurrent. They come back and back over and over again. So we'll talk briefly about immunoglobulin donations. So IVIg is prepared from plasma donations. So plasma is that straw-coloured liquid in the blood, which you can see on the picture below. 90% of that plasma is made up of water, and 10% of it is made up of solids, like the antibodies. So donations are collected by thousands of healthy donors. So the large donor pools appear to maximize the effect of IVIg. So the more donors you have, so you sometimes can have 2,000 to 50,000 donors in one batch of IVIg, and that just it gives you a lot more antibodies. So it's really a big soup of antibodies. So how are immunoglobulins made? So it's a really it's not just a simple procedure. So when you present to the blood donation centre and you want to donate plasma, you can't basically just go in and donate your plasma. You have a really rigorous screening process. So you get asked a comprehensive history. They also ask you about any risk behaviours that may have led you to develop any illnesses. They do a physical and then also do an array of blood tests for things such as HIV, Hep B and Hep C, plus other ones. So if you get the go-ahead to donate and they're happy with all of your history and your medical tests, they then take your plasma. That plasma is tested for all those viruses again, so Hep B, Hep C and HIV and other ones. It's then held for 60 days before it's used in case there's any information that comes back regarding any viruses that are picked up, or there's information regarding the status of the donor. If that donation has been held for 60 days and it's all fine, it's then pooled into a big plasma pool. Once it's pooled again, it's tested again for all those Hep B, Hep C and HIV viruses, plus other ones. It then goes into production where it's made into various other proteins as well as immunoglobulins. So plasma can also be broken down into things such as albumin or clotting factors if for some reason your blood's not clotting. Once again, while it's been in that process, all viruses are inactivated and eliminated from it again, and then it's finally pooled into vials. This process can actually take up to a year. So the current IVIg available in Australia, so there's actually 5 products, but for 4 different brands. So the first one is Intragam 10. Oops, is Intragam 10. That comes from unpaid Australian donors. We then have Flebogamma 5, Flebogamma 10, Privigen and Gamunex, which all come from overseas donations, and those donors are actually paid for their donations. So administration and dosage of IVIg. So IVIg is given intravenously, which means it's given through a drip. So often it can be given through your portacath, your PIC, or just a normal cannula. The dosages and administration vary by product, weight, and by diagnosis. So somebody who's having it for an immune disease might have a higher dose than somebody who's just having for replacement reasons. And then it's based on different products and also your weight. The infusion is usually started very slowly, and gradually increased, and this is different per product, so every different product is incremented at different rates. It's best administered at room temperature, and this helps to reduce side effects. And while you have your procedure, your nurse will monitor your vital signs and manage any side effects or reactions. So what to expect at your treatment? So it's one of the biggest and most important factors with IVIg is just really to be well hydrated before you actually have your infusion. So what it's suggested in the literature for Privigen and Intragam is that you have 8 cups of water for women and 10 cups of water for men. This is obviously, if you have any kidney or heart issues, is something that you need to discuss with your doctor because that fluid may be too much for you. And we also suggest that you have you hydrate the day before your infusion, the day of your infusion, and the day after, because this definitely helps to reduce any side effects. During infusion, you'll be in a chair, or sometimes if you're very lucky, you might be in a bed. Infusion can take anywhere from 2 hours to 4 hours, but this will depend on your dose and your rate of infusion. I have looked after people where they have the infusions over the whole day due to reactions, so it's very, very individual for everybody. Your vital signs will be monitored frequently. This does vary to different products, so but generally they'll do it before you start your treatments, every 15 minutes to 30 minutes, and then hourly once you've reached your maximum rate. During your infusion, let your nurses know that if you feel unwell, because they'll help you to reduce the side effects. So if you feel like you're getting a headache, or you're feeling nauseated, or you just feel that something's not right, let them know immediately so they can take steps to deal with any related any side effects related to your infusion. After your infusion, you may need to stay for a while. So this is also individual to different products. So often they recommend you stay for an hour post-procedure. So side effects, the most common side effects are low-grade fever, headache, achy muscle and joints, nausea, stomach pain, and back pain. The more rare side effects are shortness of breath and wheezing, chest tightness, skin rash, dizziness, low blood pressure, and I have had patients that have experienced high blood pressure. So possible causes of the side effects. This is actually largely unknown. So there's some theories behind it. So there's some theories that when the IgG molecules actually stick together, they clump together, and they actually activate the complement system, which causes almost like a reaction when you come into contact with a virus or a bacteria. So you might get the fever, the nausea, the headache. So they believe that's one reason. Stabilizers, so different products are stabilized with different things. So some products are stabilized by sugars, some products are stabilized by protein, so sometimes that might be a reason why people get side effects. Sometimes there's a small amount of that IgA that I touched on. Some people can get some reactions from that. Some products have sodium in, salt, so they may affect people with kidney problems and may affect your blood pressure. Ingredients that are added during production. So when I was telling you, when you're breaking down into different proteins, different solvents and detergents are used to draw out different proteins. So sometimes a minuscule amount of those can be left in there, and that's what can cause the side effects. And also any other contaminants that might be present in the IVIg. And then also IVIg can interact with antigens, like we spoke of, those foreign bodies such as bacteria, viruses, and that's what can cause those reactions as well. So managing and preventing side effects. So generally, if you're having your infusion and you are experiencing any side effects, the first thing that your nurse will probably do is stop your infusion for a period of time. Depending, they may notify the doctor, or they may have some orders from the doctor in case you react. They often will give you some intravenous fluid, which is normal saline, which is salty water, and that often helps to settle down those side effects. And then they'll just treat the signs and symptoms. So I might give you paracetamol, an antihistamine, and a steroid if the reaction is quite severe. And then what they usually do is start your infusion again at the rate you were before you had your infusion-related reaction or side effect. So if you went up to 90 and that's when you reacted, they might drop you back to the 60 that you want. And then in some cases, the rate might not increase further on that day. They might try and do it on further infusions, but that's also up to the nurses and doctors that look after you. Some patients actually receive pre-medications to prevent these infusion-related reactions or side effects. So paracetamol, that's often given for reactions and to prevent reactions because it helps with low-grade fevers, it helps with the flu-like symptoms, headaches and muscle spasms. And the antihistamine helps decrease the body's reaction. So when you're getting all these antibodies coming into your body, that's often your body reacts to that. And so the antihistamines actually helps reduce that reaction that you have to the introduction of these antibodies. And a special note that if patients do suffer from migraines or headaches on a regular basis, and it's a known condition for them, it is possible that they will be more likely to suffer from migraines and headaches during the infusion. So often it's important to have a plan and process with regards to your migraine medications, whether your doctor gets you to take it before or you just have it on hand written up in the infusion lounge so you can take it. And also if you have a cold or chest infection the day of your infusion, sometimes you're more likely to have a reaction because your body is already fighting infection. Sometimes they might choose to postpone your treatments because you're not feeling very well, but then other times they might weigh up the pros and cons and say you really need these antibodies to fight any infection, so we will go ahead, but we will manage you carefully. So I just got a short patient story. So thank you to this patient who's one of our Lymphoma Down Under members. She shared her story. So JH is a female patient. She has follicular lymphoma. She's had chemotherapy and other treatment for this, her follicular lymphoma. And that chemotherapy depleted her immune system. So the doctor, her hematologist, decided that she wasn't going to be able to her immune system wasn't going to be able to recover on its own. So he decided to give her monthly infusions. She has monthly infusions of Intragam 10. And prior to actually having it, she was having really frequent chest infections, and that's why he decided to put her on the treatment. So monthly infusions of Intragam 10. So as I mentioned earlier, Intragam 10 is the domestic product. So doctors like to use the domestic products for our community and hematology and oncology patients because it actually always has the antibodies and immunity needed for people in that community. So it's really, they try their best to give patients the Intragam, which is the domestic product. Her Ig levels are now stable. She no longer is experiencing recurrent chest infections, and she doesn't need any other prophylaxis medications for infections. So thank you very much for sharing your story. So I'm going to touch briefly on subcutaneous immunoglobulin therapy. So it's still giving antibodies, but instead of giving it intravenously, you're giving it subcutaneously. And what that means is it's given in the fatty tissue just under the skin. This treatment can be done at home, and you can either use a mechanical infusion pump or you can use a syringe when doing it at home. So who can receive subcutaneous Ig, and what are the products available? So it's the same for patients who have acquired hypogammaglobulinemia secondary to hematological conditions. So that's somebody who had a normal functioning immune system before. They went and developed for example, lymphoma, so they will have a low immune system because their B cells are not functioning properly, or then they've had treatment and that's when their immune systems have been wiped out, so they can receive it. It can also be given post hematopoietic stem cell transplantation. Now, SCIG is approved in Australia for specific conditions, so not everybody who has intravenous IVIg can go ahead and have subcutaneous. So it's also doctor's preference. Sometimes with hematology patients, doctors would prefer their patients come to the centres to have these treatments because they can then assess them and see their patients and see that they're well. So sometimes some doctors prefer not to allow their patients to do it. And also sometimes you just need to check whether you meet that specific criteria for receiving these products. So the two products that are currently available are Ivigam and Hizentra. Ivigam is a domestic product, which is made of Australian donors, and Hizentra is the overseas product made from overseas paid donors. So the benefits, why would you have SCIG over IVIg? So first of all, you can have it at home. It can be given at times that fits in your routine, so you don't have to go. You can do it really whenever. You can do it in the evening when you're watching TV, or you can do it at any time really. It allows you with more flexibility and independence. Fewer hospital visits, so you don't have to go in monthly, 3 to 4 weekly to get your infusions. It's less expensive because you actually don't have those hospital visits. It takes approximately 1 hour, 1 to 2 days per week. And the good thing is that your levels of immunoglobulins don't go up and down, because when you receive it intravenously, you get a peak of all these antibodies and then they drop over the lot. So if you're having it every 4 weeks, it sort of peaks at the 2 weeks and then starts to drop down. So basically you're getting, with the subcutaneous, it means that the levels are more stable, and you may get fewer infections because you don't have that drop-off period at the end. So yeah, no wear-off effect. The side effects, so you can get those same side effects that you get with intravenous, which is like headaches and nausea and sometimes a rash and back pain, but they're a lot less than what you would do if you had it intravenously. The most common things are site reactions such as redness, swelling and itching, and then at the bottom there you can actually see a really mild reaction on the left, and then on the right, a more moderate one looks like a bit of a pancake. And these usually settle 1 to 2 days after you've had your treatments. And then as you have more and more treatments, you have less and less reactions on the skin. So just a few interesting facts about some immunoglobulins. So as I mentioned, Intragram is preferred for hematology and oncology patients because it's actually the herd immunity, so it's the antibodies of the community. Australian donors are not paid for their donations. The overseas products have only really come into demand because there's been such a huge increase in demand for the need of IVIg in subcutaneous Ig. So because it's been used for so many more conditions now, they've needed to bring in overseas products. These products change every few years, so you might be on something for quite a few years and all of a sudden you might notice you go to something different. That's because that's what the National Blood Authority does every few years. So you may get the same thing, but it may change. The products are not all the same. So for example, some products have sugars, are stabilized by sugars, and some are stabilized by amino acids, which are proteins. And so they can all be slightly different. So some of the batches have different concentrations of antibodies as well. And obviously, you're not going to get the same antibodies in different batches. The costs are between $45 and $58 per gram. So as you can see, it is quite expensive. And at the moment, currently, there's actually some studies or trials being done on people who have just had COVID, and they are seeing whether it actually helps with acute disease or may prevent worse disease. But there's no results yet from this trial. So as you can see from the cost of IVIg or immunoglobulins, it's very precious, and it's actually worth more than twice the price of gold on a gram for gram basis. So for patients who need it, it is priceless. So practicing some good hygiene is the best defense against illness. So we're just going to touch briefly on this because it might just be a few things we already know, but worth going back over. So always really important, currently in this time as well, is to wash your hands thoroughly and very often for at least 20 seconds. If you can't wash your hands, then at least use some alcohol-based hand sanitizer. Avoid touching things in public places as much as possible. Avoid touching other people. So, for example, don't shake hands or hug if you don't need to. And if you do sneeze or cough, just to do that into your flexed elbow or tissue. And then try to avoid contact with people that are unwell. So practical tips for keeping healthy. So very important for this category of patients who have lowered immune systems and don't actually have antibodies. Making their own antibodies to fight infection. It's really important to get your annual influenza vaccine as soon as possible. For patients who have weakened immune systems and who may have had chemotherapy and immunotherapy, they might require a booster flu vaccine. So important to discuss that with your hematologist. Really important to eat a healthy, balanced diet. Drink plenty of fluids to really help you strengthen your immunity. Ensure you wash and cook thoroughly, your food thoroughly, get plenty of rest and manage your stress, and then keep physically active as much as possible to do so. So for more information, there is a brochure. If you can click on these, and it takes you to information about IVIg, and then it also takes you on some information on SCIG. We can post these on the site later if you want them, and also what you need to know about immunoglobulin transfusion. All right, so just to end off, I know this session has probably been a little bit shorter than some of the other sessions due to being it's not a really common topic. So just to end off, I'm just going to tell you, I know Donna touched on this briefly about lymphoma, our website. So as Donna mentioned, we are doing a new website, so there is going to be a page on immunoglobulin replacement therapy and a fact sheet to come as well, so keep looking out for that. Hopefully at some stage we might get somebody to do a session on immunoglobulin replacement therapy on Lymphoma Australia, and plus this session will be available to be rewatched. And also we do have our Facebook groups, the Lymphoma Down Under, and then also the Lymphoma Nurses Down Under. And then we also have the Hodgkin lymphoma, the CLL and mantle cell Facebook groups. And then we have our newsletters, which get sent out monthly. So sign up to those if you haven't, and you'll get up-to-date information on everything that is going on at Lymphoma Australia. And then just these are some of the websites. And then we do have the nurse support line. So this is a Monday to Friday business hours support line. We have an email as well as a telephone number. So if you contact us, if you have any questions, or if you wanted to talk about anything or find out any further information, we can help where we can. So is there any questions?
Excellent. Thank you, Sam. That was really good. I think it's good to sort of have a really good overview, even if you've been having this treatment for many years, and it is quite complicated understanding all the different antibodies that we have to actually help protect us, the immunoglobulins and things like that. So it was really good. Thank you so much. Sorry, my computer does keep cutting in and out. I've got a bit of a problem, so sorry if I do cut out in a second. But are there any questions at all? There's no questions so far, but I guess one question I've got, because it's been a few years since I've given Intragam, actually. It's been off the wards for a little while, but is it still it used to be like every batch or every different type of bottle you had to actually restart from the start again with the infusion, so it's changed a bit now?
Yeah, no, you don't need to do that anymore. So I think it sometimes can be based on facility too. I've worked in a few places where some areas have wanted to restart, but as per the guidelines, you don't need to go back to
Right, because I remember when I used to give it used to take so many hours because we had to keep starting back to the start. A really long day for patients, so that's good to know.
And they also do suggest that you start with the little bottles. So if you've got like lots of different bottles, start with the baby bottles in case. So if patients do have a reaction, then you're not wasting a whole big bottle of 200 mils. You maybe just a smaller one as well.
That's a very good idea. Yeah. Oh, wonderful. So I've got a couple of questions now. What's the rush from Jody? Sorry. What's the rationale for the 8 to 10 glasses of water to reduce side effects or?
Yeah, so most of the headaches that come from immunoglobulins often due to, because if you think about it, when you are giving, so when we take out the plasma, as I said, 90% of it's water and then the 10% of those proteins. So when we're giving immunoglobulin therapy, we're giving a large amount of protein. So it just tends to, it's almost like it dehydrates patients. So that's why the fluids is a really important thing.
Okay, I can imagine with higher proteins or the fluid tissues, is that correct?
Yeah. I think it's just the higher concentrations of, so you find and we touched on this briefly yesterday, so if you got a 5% concentration so for example, phlebigamma is 5% and a 10%. So if somebody gets headaches and side effects, they'll often change from a higher concentration to the lower concentration because that's got that extra fluid, which will hydrate you. Lost you, Donna. You there? I can answer some questions if you want while you're frozen. So okay, I can answer.
My computer keeps freezing. I don't know what's going on. So sorry, just keep going.
All right, so the question about can SCIG be used for different antibodies? So at the moment, it's only used for immunoglobulin G, as I touched on. So yeah, there's no replacement therapy for any other different antibodies. Hopefully that answers the question.
Anonymous has asked, if immunoglobulins don't stimulate your immunoglobulins, how long do they remain helpful?
3 to 4 weeks. So that's why, so that's why mostly, so patients who have for primary immune deficiency or replacement therapy, like after having chemotherapy or because the lymphoma is destroying your B cells, it's usually, they peak sort of at the 2 weeks and then the body starts to break them down. So it's really between 3 and 4 weeks. That's when it runs off, yeah.
And I guess also it doesn't stimulate your own immunoglobulins too much. Just to replace because you haven't got those.
Yeah. So it's almost like when you have a blood transfusion, you're just giving them the blood, but it doesn't actually stimulate your body to make their own blood cells.
Yeah, to replace it and give your immune system a helping hand, so to speak. Yeah. Mary has asked, for patients who have had IgG post-bone marrow transplant for decades, we still start with a rate of 60 incrementing to 240 mils per hour. Is it necessary for patients from St. V's to tell us they go straight to the maximum rate? So I think that's what you were saying before. Do you start slow and then go up and just stay at the high rate?
Yeah. So generally, when I worked in Infusion Lounge, we would have, there are a lot of patients that would come and go, I've been having this and I gather from how much she's having, it's an intragam, it's a domestic product because that's the increments for them and the maximum rate. But a lot of patients will come and say, oh, just put me at 240, I'm always fine at that. But it's always safe to just go to that 60, 120 and then 240. So, yeah.
Yeah, it's a little bit different to me.
But then it can, some facilities may be happy to put you straight at 240, but that's not to say, the product information says that you should increment it. So that's the safe thing to do, but it can be, the doctors can decide if they want to do it differently if needed.
And I think there's information on the blood bank site, isn't there, about all the information we discussed today. There's some fact sheets on there and also how to give these products as well. And I was just asked, IgD, so poorly understood in relation to B cells?
I suppose just really because there's such a small amount of them and they're just, they just don't seem to have as much. I think with IgD, it's only maybe 1% of all the proteins. So I suppose, and it's just, they're just probably not much research going into it because it's such a small concentration.
Yeah, IgM and everything is a lot bigger.
Yeah.
That makes a lot of sense. Yeah. Well, I hope you answered all your questions, everybody. Oh, hey, sorry, there's one more. I missed one. Another question, do immunoglobulins generally improve over time if you don't meet criteria for donation, but your levels are always borderline?
I'm not quite sure I understand the question.
That was over time if you don't meet criteria. I'm assuming this is a patient post-treatment who've got lower in immunoglobulins, looking at whether they can donate in the future. Is that correct? Because they're a bit borderline treatment. I'm assuming. So generally, if that's your question, sorry, you can always give us a call on the nurse line a bit later if we haven't answered it properly. But I'm assuming patients have had treatment. Usually over time, most patients do immunoglobulins, their immune systems do recover. But unfortunately, some patients, especially with depending on the type of lymphoma or CLL you have or the amount of treatment you have. So some of these treatments can really hamper people's immune systems, especially after, transplants with a high dose of chemo. So that hence they may not replace, but generally most common treatments, generally over time, sometimes 6 to 12 months after treatment.
But also, I don't know, I also read it a slightly different way as well. If somebody, I was just thinking, we're listening, I think if, I suppose some people have lower levels, but they're not, with having a replacement under the National Blood Authority for it being funded for a specific indication, the patients have to be symptomatic. So you might have lower levels, but if you don't actually have any infections, so you're not having chronic sinus infections, ear infections, chest infections, lung infections, then they may not be able to, you may not be indicated for it, but then sometimes there are special reasons that you can go and apply through the National Blood Authority that your doctor will do.
They're very strict criteria because it's so expensive.
Yeah.
It's a great way we can take it like that. Yeah, it's good. If I'm feeling well, I will walk 3 to 4 kilometres prior to the infusion and even walk home. If one is encouraged to drink this amount of water, should I cease this exercise?
No reason to. I mean, probably both of them are really good for you. So if you can, I mean, that's what they recommend on some of the information, to drink that amount of water. But I mean, if you're managing to walk and do exercise plus drinking, there shouldn't be any reason why you can't do both of those. So from my point, yeah. But
I think go for it. The exercise.
You might need to find a loo on the way.
That's true. Maybe drink a little bit more water just to recover that. It depends how strenuous you're walking. I take things too. And lastly, I think it's the last question so far. Jody has asked, are you seeing a bigger change over the subcut IG versus the IV version, especially in the COVID environment?
I think that when you go from intravenous to subcutaneous, it's not just a matter of going into your clinic and having your infusions and then deciding to change. I think the thing is as well, you have to get training how to do it. So that usually involves you going into the hospital. Somebody spends like 4 to 6 hours with you, training you up how to do it. And then you have to come back usually to make sure that you're doing it properly. So it is a little bit of a process. And I suppose doctors still want to keep a close contact on their patients in this environment, in COVID environment. So maybe starting new treatments, I don't think there would have been a huge amount. Subcutaneous is also not used massively in hematology because the hematologists do like to keep close contact and eye on patients. And for them, coming in 3 to 4 weekly for their infusions is a way of them reviewing and being able to see that they're okay. So, yeah.
It's definitely something, especially if you live a long way from your treating centre, it's a good question to ask your doctor if you're eligible. I think it helps. And another question, why don't we pay people in Australia to donate in order to increase their supply and herd immunity?
It's against our constitution. The government doesn't, it's just not constitutional. They want us to donate for an altruistic reason, not for monetary. So,
so no donations are paid for in Australia for blood products. And also, I guess the reason why, so it's that question pretty well. Excellent question, though. I think that's all, Sam. I think we're going to let you off the hook. Thank you so much. It's really good. It's a topic that, obviously I know bits about, but I think I've learned more from listening to that presentation. So thank you so much. Thank you again, everyone, for joining us again today. And we'll be sending out an evaluation, so please fill it in. We'd like to hear from you, hear how we're going, and we're getting really lovely feedback, so thank you. And also we're recommending any future topics that you want to hear about. So thank you so much, everyone. Have a good day.
Thank you. Bye.
Bye.